And Sherry, thank you for joining as well. I'm going to kind of kick things off here a little bit and welcome everyone. Thank you for being here on this Health Insurance Committee teleconference hosted by our State Health Chair, Craig Rodriguez. Craig is doing a fabulous job for us so far on the statewide board. And as he moves on to the board in 2020, helping us get organized, so on and so forth. So nice of you to be on. Just a heads up that we are recording this teleconference. We'll make the link available to others later if they weren't able to join us today, and we'll get that out to them. Now, an interesting feature about the recordings on Zoom is you can choose the speed at which you choose to listen to it. So you can go 1.5 or twice the speed normal. Everybody sounds like Mickey Mouse, but it is interesting. It's an interesting way to experience Zoom if you don't have a lot of time to spend an hour and a half in real time. So just an interesting feature there for you, just so you're aware. This morning, we did have our president's teleconference as part of the association planning meeting. Our incoming president for 2020, Joe Challam, hosted that meeting. And I will tell you, he did a great job with that. And we had 11 people on that call, and was delighted to get us kicked off very well with that particular teleconference. So right now, I'm going to turn over to our incoming state president, Joe Challam, who will introduce more formally Craig Rodriguez to you.
Thanks, Tom, and again, thanks to everyone for being on the call. 2020 is just around the corner, and wanted to share with you my vision for those of you who are not able to attend the state conference and maybe listening in the future. The focus is really on membership and leadership, because without those two elements, we don't have anything. So really looking forward to working with everyone. And I know this is primarily about health insurance, but let's face it, every call is about membership. And I also encourage everyone, every health chair, to have a succession plan, have a co-chair. I think that's really important in developing the leadership in depth, so that we can keep on flowing and keep on bringing up new people and breaking them into and help educating them. And a couple of other things, and then I'll be turning this over to Craig, is I want to make sure that you're aware of some resources that are available at the state and national level. At the state level, this is more for membership, but join.nafa-florida.org is a landing page. And you're probably already familiar with the progressive membership program that's been blessed and formalized by NAFA, which is the 10-20-30-40 program for newer agents. And there's a leadership page that Tom will be emailing out later on to make sure that you have that link to that leadership page. And something that I'm excited about is the Idea Incubator, because really we're an association and a profession of ideas. I mean, we don't have a tangible product; we have ideas and concepts, and really encouraging everyone to contribute any ideas that you have. We're going to be creating an email address called idea@nafa-florida.org. Prior to that coming on board, if you have a thought you want to share, just send it to Tom or send it to myself, and we will be happy to take a look at that idea and see, if we can implement it or get back with you to develop it out. Okay, well, I want to welcome Craig Rodriguez, who's going to talk about his plans for Health Committee for 2020. So, Craig, take it away.
Well, thank you so much. I appreciate it, and thanks for having me here. I don't know hardly anybody on the call, so hello. Nice to meet all of you. I'm taking over as the health chair. George and then I guess Terry before that have been doing this, and so I have a couple of things on my agenda that I'm interested in trying to accomplish, so I'm excited to try to share that with you guys, see if anybody has any input about what we want to do. I won't take up too much of your time. I know any of you that are writing health insurance, fourth quarter is a big deal. It's a big deal for us, and I'm sure it's a big deal for you. So we'll go ahead and get started. Tom, maybe you can bring up the first slide. So I've got two different things that I want to try to work on. The first one has to do with the group insurance. Do any of you guys write group insurance? I can't hear anyone.
Yeah, I
so
do.
I don't know if that's a... Okay, great. So if you're writing group insurance...
Yes, I do.
Okay, perfect. So when you're writing group insurance, you know that we end up using three different definitions to decide between small group and large group. So if you look at this chart, what happens is if you're writing a self-funded group, then we're using the number of eligible employees. The idea here may be there's 30 full-time people and 50 part-time people. Well, self-funded plans just use how many people are eligible, 30 in this case. If you're doing a fully insured plan, then you're in this middle column because fully insured in the state of Florida deals with average total number of employees. So in my example I just gave you, they would count that as an 80-person group, making it a large group and having us deal with all of the large group scenarios involved in that. And then, of course, we all have to deal with full-time equivalents based on the federal law. What I want to try to do is I want to try to get us to two definitions. So Terry Seafelt and I and some other people started trying to work on this last year, and we went to Tim Meenan and we said we want to change the definition of a large group, and Tim couldn't find it in the law anywhere. And then it was this year I was reading something a couple of months ago and finally realized the problem was he was looking for definition of a large group. The law actually defines definition of a small group, and what we want to do is we want to use eligible employees as the only definition. Now, we still have to deal with full-time equivalents because that's federal law, but we'll want to eliminate AT&E and just get rid of it altogether and only use eligible. Since I have two people on the call that said they write group insurance, would you guys be in favor of having one definition to decide what a group is? Eligible employees?
I would, yes, sure.
Because our idea is that's the truest picture of who a group is whoever's eligible. All the part-time people don't matter. So that's one of the things that's on my agenda. We actually, at the NAFA board meeting, I got a chance to talk to Tim Meenan about it, go through this with him. There's some additional pages attached to this. I don't know that we need to spend a lot of time, Tom, going through those. But if you look at the top of this sheet, it actually gives you the code section for all of these groups. 627, you know, .66993 W2. The idea here being you can't change anything in state law unless you can point and go, this line, this sentence, this spot we want to change to read X. So I made the proposal, and Terry Seafelt backed me up to make the proposal, and she was trying to make this done anyway, to change it to just eligible employees as the definition of a small group and a large group. We talked to Tim Meenan about it. He gets it. He's going to try to go and start talking to some of the congressmen and senators about that. So I'll pause for a minute and see if anybody has any questions or anything about that.
So you want to do this to simplify the definitions? Is that the purpose?
That's correct. Right now, if I submit a census and I'm getting a self-funded quote, that's one census. If I want a fully insured quote, that's a different census with different information on it. And then we still have to track full-time equivalents, which is federal law, and we're thinking, why are we using multiple things? Who's eligible is the truest picture of who's in the group anyway. Not the 50 part-time people. They don't matter. They're not eligible for coverage. And so that's our idea. If you guys have questions about it, I would be more than happy to talk to you about it. It's something we're trying to work on. I'd love any input. I've actually tried to find some carriers to reach out to, so I spoke with Humana the other day, and Humana's going back to their underwriting department to talk to them about it. I've spoke to Tim Meenan. I've tried to ask whatever agents I can find to see if it's something they'd be in favor in. I can't figure out who would be against it other than maybe a couple of groups that benefit by being large group when they get changed to small group. That's going to be a really small number, and a whole lot more people are going to benefit by being small group that are large group today, through denials and all that kind of stuff. So if you know anyone well at a carrier, I would love to get their opinion about this. If you know people at health underwriters, I'm trying to get health underwriters to come on board with us so that, us and health underwriters and the carriers are all saying, yes, Florida, let's make this change, and hopefully that makes everybody's life easier.
Craig, have you spoken to the president of health underwriters in Florida?
I don't know the Florida president. My friend Reggie Robbins is the local president this year.
Mm-hmm.
I've talked to her about it, and she was going to try to talk to her lobbyist and see what they have to say. I don't know who the Florida president is.
Well, the Florida president actually works with your friend George.
Oh, okay, good.
I'm looking up her name because I don't recall it. But I did have a conversation with her, Debbie something, and there seemed to be some interest in maybe us doing some shared programs or something along those lines. So as soon as I find her name, I will email it to you.
Okay, awesome. Yeah, and I can talk to George about that. I just kind of figure if it makes sense and we all are in agreement, why not try to get more than just our lobbyists working on it? Maybe we can get them to work on it too, and we can get something done.
Yep, good idea.
Okay, awesome.
Right.
So that's the idea.
I'm sorry. Have you spoken with Tim about this? Does Tim feel like this is something that we can push through or can get passed fairly easily?
Tim felt good about it after we had the board meeting. Until then, he couldn't figure out where to change it, but then I showed him where I thought it was in the law. We kind of got a chance to explain in person what we wanted to do, and I think he feels pretty good about it at the moment. He feels like that's something he can get done because it's a pretty minor change.
Yeah, okay.
All right.
Good.
So that's one thing I want to try to work on. I have a second thing I want to try to work on. This is a really big deal, and it's a little more complicated, and it's kind of like my moonshot. If you're going to take a moonshot, here it is. If you can bring that other flyer up. All right, here's what happens is in Florida, we have people that are on Medicaid. So if you're on Medicaid, then you pay nothing for the Medicaid. You pay nothing to go to the doctor, nothing to go to the hospital. It's a really good plan for the most part. And a lot of people apply for Medicaid, but in Florida, we only give Medicaid in general to children, pregnant women, and some dual eligible adults. So we're talking senior citizens, Medicare, and Medicaid. We also have a second program called Medically Needy Share of Cost. Now, Medically Needy Share of Cost, like if you look at this letter right here, it shows that this person got a plan with a deductible of $2,092. So you may think, well, heck, that's not that bad, $2,000 deductible, until you realize it's actually a $2,000 monthly deductible, meaning this person has about a $25,000 a year deductible.
Wow.
Who gets medically needy share of cost? A lot of times this is the single mother of some children, somebody like that. They'll give the mother this medically needy share of cost. They'll give the kids Medicaid, and we think we gave them a good solution. Prior to the Affordable Care Act, I'm not sure it was a good solution, but it was probably better than nothing. Since the Affordable Care Act, what's happened is if you're eligible for Medicaid, you are not eligible for a subsidy on the exchange. But medically needy share of cost is not Medicaid. So these people are eligible for a subsidy on the exchange, except no one realizes it. None of the agents really realize it because all they hear is Medicare and they never studied the law enough. And people at healthcare.gov certainly don't realize it, and the people mark that they have Medicaid when they do an application on healthcare.gov. So what happens is these people end up stuck with these plans. if they're stuck with this plan, and let's say you're a diabetic and you want to go to the doctor, you try to go to the doctor, but the doctor refuses to see you because they know you can't pay $2,000 in medical expenses. At that point, what they do and what's recommended is they say, well, just go down to the emergency room and tell them you have some chest pains. That'll meet the deductible, and when the deductible is met, the person doesn't owe anything, including the deductible. So everything's covered at 100% once they break $2,092 in this case. Well, that's not, then they can go back to the doctor and the doctor will see them. Well, at the end of the day, that's not good for us as citizens of Florida, because we're encouraging people to rack up needless claims because they don't have a choice. It's not good for the insured because the insured can't just see a doctor when they want to. They have to go to the emergency room, and everybody encourages them to go to the emergency room and rack up fake cost. My proposal is, in a perfect world, I'd like to eliminate medically needy share of cost. Tom, if you go to page 2, I think it is. Let's go down one. Yeah, so as an example, this exact person could go on healthcare.gov and get a plan. The plan's going to be like $5 for the doctor. You can stop right there. $5 for the doctor. You can see the deductible is $950. The out-of-pocket maximum is $2,600, and it costs them $77 a month. People may say, well, gosh, Craig, they don't want to pay $70. Well, there's plans that are zero if they want to do a bronze plan. But this is actually better for them because the network is better, the provider list is better, they can fill prescriptions without having to meet this huge deductible. So in almost all ways, this is better for the insured, it's better for the state of Florida, it's better for the hospitals because they're not getting a bunch of fake claims that they don't need and a bunch of emergency room visits that aren't real. So my moonshot here is I want to try to do something with medically needy share of cost. Almost everybody that we move off of that plan onto a healthcare.gov plan, they're super grateful for all the reasons that we already talked about. And so I've talked to Tim about that. Tim and myself and Terry had a conference call with a few former politicians. It was an interesting call because the politicians are like, yep, I completely get what you're saying. The question we have is, how's this going to look? And I guess they mean, how's it going to look politically to come out and say you want to cancel medically needy share of cost? But there's this long silence, and Craig says, I don't know, like we saved $1 billion. So it is a moonshot. Tim's going to try to take a look at it. He knows the person that's in charge of coming up with the money to do the medically needy program, and so he's going to start with them, and we'll see where we go from there. And so I'll stop for a minute and see if anybody has any questions.
Yeah, I actually do. So what we're looking at now, is this part of the Affordable Care Act that we're looking at? Or
yeah,
is this...
sure is. So as a state, we'd be transferring our risk of paying these claims to the federal government.
And if something happens, I mean, obviously there's been a lot of political discussion about eliminating the Affordable Care Act. In fact, last session in Tallahassee, there was legislation that was passed to try to make a transition plan in case that should happen. So, I mean, the way I see it is that I wouldn't couch it as you're eliminating the medically needy plan. You're transitioning them to a much better plan.
You're absolutely right. And Tim's even kicking around the idea of, instead of us paying for medically needy, can we just pay the $70 and enroll them in a healthcare.gov plan and be done with it?
But there's something I don't understand, because I don't do underage health insurance, but it's my understanding that in order to get the subsidies with the Affordable Care Act, you had to have a certain level of income, like about $1,000 a month, in order to even qualify for it. And I think a lot of people that are on the medically needy plan may not even have that income.
Most of all the ones I talk to have enough income.
They do. Okay.
I mean, I'm not going to say 100% of everybody, and that's part of what we could quell out in the long run. We could say, well, if their income's below X, we'll leave them here. If it's above Y, we'll transition them, and that's part of what we'd have to try to figure out. I just see it as a case where we're spending a ton of money we don't need to be spending.
So I guess the question that I have then is, we're dealing with, I guess, maybe three levels of demographic. There's the ones that don't have anything and are on Medicaid or social services, and they don't have anything at all. And obviously, like you're saying, if they've got a deductible of $2,000 a month, that's the equivalent of saying they have nothing, because they can't
Yes.
pay it. And then you have people a little bit higher than that maybe they're managing, maybe they're not on social service programs, but if you give them a program with a $3,000 deductible and $50 every time they want to go to the doctor, plus a premium, that's a challenge. So it sounds like what you're suggesting is for those people that are, I guess, a bit above the poverty line, but they're not making 50 or 80 or 100,000 a year, so they're kind of in a difficult spot.
Well, but with the Affordable Care Act, the lower the premium, the better the plan. So we literally have clients that pay 70 cents a month. It's $1 for the doctor, $3 for the specialist, 0 deductible, $500 max out of pocket. So when the lower I make the lower this premium is, the better the plan. It works opposite from everything that makes sense in the rest of the insurance world. We do backwards math. More people cost less than less people. So, Joe, you cost more than if you got 2 kids and a wife, then you cost less. So you can't apply your regular insurance world to healthcare.gov stuff. It doesn't apply. It's completely backwards. And I have seen these medically needy deductibles as high as like $4,000 a month.
Well,
who the heck? There's none of us that can pay $48,000 deductibles.
Right. I mean,
Now, who takes? I'm sorry, Joe.
No, go ahead.
I was going to ask who actually takes, or who actually goes on this medically needy share of cost program? Is there anyone that takes it?
Well, they just get enrolled. So what happens is, probably not you, but let's say your daughter was a single mother and she applies for Medicaid. Okay, we only give Medicaid in Florida to children and pregnant women. So your daughter's not pregnant, but she's got 2 kids, so they give the kids Medicaid, and then they'll probably issue medically needy to your daughter. Well, she doesn't know she can get anything else. And so she just sits around with this $2,000 deductible and says, well, if I need care, I got to go to the emergency room to get it because I can't pay the $2,000. So normally it's a single mother that ends up on these medically needy plans.
Okay. And Craig, when you said that if they go to the emergency, they will say, like you said, they'll go in for a chest pain, and the bill will come to $20,000, which includes the $2,000 deductible. Are you saying then because the state will eat the entire bill, they don't have to pay for the deductible because they went to the ER?
That's correct.
Wow.
So when they go for a legitimate emergency, that's fine. But what happens is you need some diabetes medication. The pharmacy tells you it's $100. You can't pay $100 a month, so you just start every month by running down to the emergency room so that the deductible's met. Now your diabetes medication is free, or your blood pressure, or your cholesterol, or whatever it is you want to do.
Right.
So you just start the month by zipping down to the emergency room and meeting the deductible every time you have to do something.
That's insane.
And so then we say, well, the emergency rooms are crowded and people just go to the emergency room. Well, of course, we built a plan that told them, go to the emergency room.
Yeah, this is kind of ironic because if you go back 30 years when we were phasing out of the indemnity plans, like the old, $500 deductible and 80/20, go wherever you want, and the HMOs came in to exactly reverse what you just described.
That's right, yes. And yet we have that as a plan. And so what I think happened is this all occurred pre-Obamacare. I just don't think anybody ever revamped it once they realized what the new law would do for them. And so I want to try to change that. I don't know that I even can, because I don't know what politician in his right mind would say, I want to revamp medically needy. They'd be crucified. But If you don't take a shot at it, you have no chance.
I agree with you. I
Do,
think
do we know how, mhm. Do we know how many people are on this medically needy plan, share of cost plan?
I don't know how many people are on it right now, and that's part of what we're trying to figure out. So Tim Meenan was going to take a closer look at it and talk to the guy that's in charge of funding for that plan.
Okay.
And that's pretty much where I left it with him about whenever the NAFA meeting was, a week ago, 2 weeks ago.
Mm-hmm. Okay.
But I think it's a worthy cause. I think it's a win for everyone. It's a win for the state. It's a win for the insureds. It's a win for the hospitals. I think everybody benefits.
And this plan, was it a Florida-initiated plan? Or how did it come to be?
So Medicaid, the thing about Medicaid is the federal government sets the rules for who's eligible, but the state pays the bill. So the state's funding Medicaid and the medically needy program. So that's why I say it's a win for us as citizens, because if we can do something to change the cost in this program, that's tax dollars we don't have to spend. And so it could be a huge savings for us. The exact number of people on it, I don't have that number in front of me, but it's got to be thousands and thousands. I mean, I talk to people all the time who are medically needy.
And it seems like some of them are automatically enrolled and they don't even know about it?
Well, they get enrolled, and so let's do healthcare.gov and Medicaid. If you're eligible for Medicaid, you're not eligible for a subsidy on the exchange, okay? So my daughter applies for Medicaid for her and the kids. The kids get Medicaid. She gets Medicaid medically needy. She then has this plan, calls an agent on the phone or calls healthcare.gov or even does the application herself, and it says, do you have Medicaid? She doesn't know the semantics of this. She says yes. They tell her she's not eligible for anything.
Okay.
When the actual answer there would be medically needy is not Medicaid, the answer is no. So the kids have Medicaid, she does not.
And then the other question is, once they're on this plan, they miss the open enrollment and therefore they stuck with it for the remainder of the year?
Correct. Yes.
Okay.
So I've got to catch them either at the renewal. Medicaid does some renewals. So if Medicaid says, oh, you're not eligible for this anymore, then I can catch them then and enroll them, or I can catch them right when they get it. So, say my daughter applies for Medicaid today, and then they issue the letter saying, well, you're eligible for medically needy starting November 1st. Well, that's a Medicaid denial. I could enroll her right then. Otherwise, I got to do it at open enrollment. And so it's an education piece to not only, healthcare.gov, there's no way to educate them. They don't know what they're doing. But we could also educate agents in Florida that medically needy is eligible for a subsidy. A lot of them don't know.
Well, I had no idea that that this was even available.
Yeah.
So, I mean, if I don't know, I'm sure there's a lot of others that don't know.
Yeah, and it has to be people that are dealing with this or writing subsidies on the exchange and reading the law and paying attention and whatever. So I think it can help us all. I think it can help everybody. I see it as a win-win. So that's the other thing I kind of have on my agenda. Other than that, I am looking for help. I guess we're going to try to make an appearance on Day of the Hill. My guess is won't be a lot that'll happen with the health chair at least until after January, because I know probably like the rest of y'all, I'll be working 12 or 14 hours a day, 7 days a week from now until then. But I want to try to do those things, and then I'm just going to try to get with Tim and see what we need to do to make some of that happen. Besides that, I am always trying to ask agents, is there something that you think needs to be changed in the law? And so I would encourage you guys to do the same thing. Ask people, because occasionally they're bumping into things that the rest of us aren't bumping into, and they'd say, yeah, if we did this, it would be better. Sometimes they'll give you federal stuff. Like I had one agent say, yeah, I want to eliminate the Christian sharing programs. I'm like, well, that's part of federal law. That's not something we would do at the state level. But, yeah, other than that, I would encourage you to ask people if there's something they don't think works.
So for
I don't know
those
if we
who
have.
yeah, so for those who may be watching this at a later time, who are viewing the recording, feel free to reach out to Craig if you have
Yeah.
any. Right, Craig. I mean, any ideas, any thoughts, anything that keeps them up at night, and let them know. And Craig, give them your email address too, if you don't mind.
Yeah, it's Craig, C-R-A-I-G, at CSR, that's S as in Sam, so CSR Benefits, BENEFIT, S as in Sam.com.
And by the
Or they
way,
can call me at the office too, 407-937-2900.
very good, thank you. And by the way, I just got an email from Claire. She typed a message here, and she's recommending Michelle Maluli, who's a licensed health agent out of Boynton Beach. Craig, I don't know if you know her or not. Claire says that she serves as an agent rep with Florida AHU, and she can certainly get us into contact with the right people at Health Underwriters.
Oh, that'd be perfect. Yeah, that'd be great.
And also, Craig, I emailed you the contact info for the FAHU president.
Oh, okay.
So between all of that, you should be in a little bit better shape.
Oh, good. Yeah, I don't know how much you guys have all tried to work together or not, but it seems like we're all the same people moving through these groups, so it seems like we should be able to get something done.
I agree.
Right, right. There is a message I'd like to let everyone know, again, those who are on the call and those who may be viewing this at a later time. And this message is really more specifically for the committee chairs at the local level and the local chapters or local affiliates that if you've not organized your committees for 2020, we ask you to do that. As you know, Craig Rodriguez, our state health chair, and I know he'd like to see lots of folks serving at the local level, local teams regarding health insurance matters. And, Craig, I don't know if you knew it or not, but most of our members sell health insurance, at least they're licensed to sell health insurance.
Right.
So there's a real need out there. I will tell you that the majority of the people getting licensed in the business right now are health insurance, more so than property casualty. I'm sorry, more so than life insurance, according to the Department of Financial Services statistics. So if you're a local chair, please make sure that you've got your team organized for 2020. Drop us a note here at the NAFA Florida office or at Craig's email address. Let me give you my email address if you would like to forward that information along. We'd love to have it and put it in our database so we can reach out to you and your team. Tom.Ashley, A-S-H-L-E-Y, that's Tom, T-O-M, .Ashley at NAFA-Florida.org. And Florida is spelled out. So that's Tom.Ashley at NAFA-Florida.org. And forward to me your team information, your committee team information, and certainly your information as the local health chair as well. We really do need to get our committees ramped up. And this is a message we're going to be sharing on all of these association planning meeting teleconferences this week. And that is the need for our local committees to become viable, to become robust, and become active. I know Craig could use some help, as we've seen here in his presentation. He's got some real good thoughts and some interesting ideas about how NAFA Florida needs to proceed in changing policy here in this state, and which could possibly help change policy in other states moving forward. You never know. But we need help to do that. He needs input. He needs assistance. I know your president for next year, Joe Challen, would appreciate it if we had some good, robust health insurance committees set up as well. And that was just the one thought I had. I've got a few announcements towards the end, Joe, as we begin to wrap this up. Craig, did I hit that on all cylinders? Is there anything else you wanted to mention about it?
No, that'd be about it. I agree with you. Yeah, I'd love to have some help, and I appreciate everybody coming in on the call today. And if you have any questions, feel free to call me or reach out or shoot me an email, and we'll see what we can get done.
So a question, Craig, have you given any thought to how often you're going to be having committee meetings or Zoom meetings for the health committee?
Yeah, that's a good question. I didn't actually think we would do much until after the first of the year.
Mhm.
And then from there, I think it's really going to kind of depend on, I'm not exactly sure how much we need to do that, so I'd have to try to figure that out. I don't know much about what we would try to do there.
Okay, so
We'd
it sounds
have
like,
well, you're going to have the general session coming up. Is it March this year?
no, Day on the Hill is in January 28th.
Oh my God, yeah. So I don't know why I was thinking it was March. Every year it flips between March and January, right?
That's
Yeah,
right.
every
It
fourth year.
alternates. Yeah.
Yeah. So with it being in January, we'll probably have stuff we need to do in January, and then see what's going on with our agenda from there. So I'm going to try to work with Tim some. If I have feedback or input, I can tell people about how that's going or what I need them to do. I'd probably try to get messages out to everybody. Going to be hard to do a call until after the first of the year.
So yeah, all right. So it sounds like the number of calls and the schedule for the calls will be worked out, and of course that information will be sent out to the
Yeah.
locals and to the membership at large. And I think that the other element that people need to be aware of, people on the call and people who may be listening in the future, is that our state committee system, not only our local chairs, but also our state committee system, meaning you can join all the local health chairs are automatically part of the state health committee, but other people who are in affiliates or unaffiliated members also have the capability of joining a state committee like the health committee, and that's a pathway for leadership. And so if people have interest or aspirations of serving perhaps on the state board, that's a roadmap, because once you are a state committee chair, you are eligible you actually are on the state board if you are a committee chair, and that's a pathway up through leadership. So this is really important for if you're having future leadership development, to make sure that people are aware of that and to encourage interest in that level, because we need to make sure that we're promoting leadership development and having succession plans. Just like I've asked all of our state committee chairs to get a co-chair, and because if we don't do that, we're not setting an example. And we need to do that. And the local, I would encourage the local committee chairs to do exactly the same thing, because you need to find your replacement, and that's effectively what you're doing. So Craig, congratulations for starting up in
Thank you.
January. Let's find out who your replacement is.
Yeah, sounds good. Well,
We
I'm
need to
excited.
find out who his replacement is so we can move him up to state president later on. See, so.
Oh gosh, yeah, that'd work out great. Yeah.
But don't worry, you've got at least a couple of years.
Oh man. Well, thanks so much for joining, and if you guys have any questions, definitely let me know, and we'll see what we can get done.
All right, and I've got just a couple of short announcements here to finish us out. Then Joe's going to close it. First of all, I just want to remind everyone about the National Advocacy Meeting. It's going to be held in Washington, D.C., December 2, 3, and 4 coming up. And that's really for our PIC chairs, political involvement chairs, our PAC, what we call political committee here in Florida, those chairs, local and state, and our local presidents, and of course, state leadership will be attending that meeting as well. It's really a great meeting. It's one of the most interesting meetings that NAFA puts on, actually, I think. If you're thinking about attending, we'd love to have all of you. You're welcome to. It's not closed to anyone. It's open to all. So it's Monday, December 2 through Wednesday, December 4. Just a heads up that Monday, December 2nd is the Monday following Thanksgiving weekend. The airlines consider that part of the Thanksgiving weekend package. And so if you're thinking about it, book your airline airfares early for that morning. The meeting doesn't start till around 3 that afternoon, Monday afternoon. You'll be in meetings all day on Wednesday. And then on Thursday is our day on the Hill, where we meet and have appointments with members of Congress, which is always quite interesting. And bring a sweater. It's typically cold and drizzly in the district at that time of the year, but it's really a lot of fun. Next up is our legislative day on the Hill. Our state day on the Hill will be Tuesday, January 28th, as Joe mentioned. And format's going to be pretty much the same as we've had before, except that we won't be having our dinner and open bar at the Dogwood House as we've had the past 2 or 3 years. But instead, we're going to have a nice catered dinner for you with an open bar right next door to the Capitol. Tim Meenan's office, our lobbyist, he has a brand new office right next door. It's gorgeous too. If you've never been in there, he'll be glad to give you a tour of it. He's got a nice courtyard out there in front of his office, and it's like I said, right across the street from the Capitol, and be a great outdoor setting. It'll be January in Tallahassee, so again, bring a sweater here. It'll be kind of cool. It may not be cold. We don't get cold like we used to, but it will be cool for sure. And then finally, the Congressional Conference next May 19 and 20 of 2020. This is the NAFA Congressional Conference and is the equivalent of our state day on the Hill here, except that it's at the national level. And that is the true congressional day on the Hill, where NAFA members from all across the United States go to Washington. We have meetings with NAFA the day before the visits, and they go through the talking points. We huddle up as a group. We visit the members of Congress in group fashion with team leaders and all that kind of stuff. If you've never done the Congressional Conference, it's a fascinating thing to do. I know, Stas, you were there last year and years before. It was good to sit with you on the bus headed over there and chat about some things.
That's right.
So it's really one of the more interesting things that NAFA does, I think, is that Congressional Conference. So at any rate, my thanks to you, Craig, again for conducting this teleconference. Thanks to all of you who are on it. Thanks to those of you who will be viewing it at a later time, and thank you for the work that you do. And that's it for me. Joe, I'm going to turn it back over to you.
Thanks, Tom, and thanks, Craig, for moderating this this meeting. So I just want to get a little feedback. Do you like conducting this type of meeting in this format, or would you prefer to drive 100 or so miles and meet in person?
I'm good. I like this.
Okay, so I got Craig's thumbs up. Stas, what are your thoughts on this?
Yeah, I think that this is a lot more time effective. I mean, we can sit here and carry on doing whatever we're doing, and then break out for an hour or two and have a meeting and be able to see one another and see reactions. So I think this was great.
Good. Okay.
The only problem is we can't meet at the bar after the meeting's over with.
Well, we can meet at a bar. And then you see what you do is you have one of these gadgets, and you simply connect that way, and you can sort of, maybe not exactly the same thing, but we do what we can.
Yeah.
But
outstanding. Thank you very much.
Anyway, thanks very much, Claire. Thanks for joining us again, and hopefully you can get your audio issues worked out so we can hear from you. And again, as Tom said, and Craig said, we really welcome your ideas. I think Craig's got some great objectives and goals to try to accomplish this legislative session and brings to light a really interesting and unfortunate issue with the medically needy program, because it's like saying, you've got a scientific solution. You think you created a solution for people who desperately need health insurance, but then you made it so expensive and designed that they can't use it. So it really doesn't make any sense. But thank you for spending some time and highlighting that particular program that needs modification. Thanks so much, and I'm sure that you'll be receiving some communication from Tom's office about future meetings, and Craig, I look forward to working with you as well as I do working with everyone this year. I should say next year in 2020.
Well, thank you. I appreciate it, and have a great day.
Thank you.
Thank you.
Thank you.